Michelle did her undergraduate work at the University of Tasmania and then her PhD at the University of British Columbia. And she's now a distinguished professor of psychology and psychiatry and behavioral sciences at UCLA, where she is also the Kevin Love Centennial Fund chair and director of the Anxiety and Depression Research Program and the co-director of the widely known and envied UCLA Depression Grand Challenge, and is also acknowledged as a world leader in depression and anxiety research. She's published over 650 peer-reviewed publications. She's had a career of successful obtaining of grants and maintaining of a lab, and has really been a person who changed the way we think about anxiety and depression. I really appreciate her coming here today, and please join me in welcoming her.
Great, thank you very much for inviting me to be here. And I'm going to be focusing today on quite mechanistic research about how we conceptualize depression and anxiety from the point of view of threat and reward processes. I'm not going to be talking much about the work we're doing in the Depression Grand Challenge another time. It's a whole nother body of research that I think is quite interesting too, of course. So my research focuses on two core motivational processes that guide our emotions and our behaviors. The defensive system, which motivates avoidance of punishments and is associated with negative emotional states such as fear, anxiety, and guilt. And the appetitive system, which motivates us to approach rewards and goals associated with positive emotional states such as joy, excitement, and pleasure. And my goals today are to talk about our latest work in terms of advances in our understanding of the defensive mechanisms and their treatment implications, how we understand the latest in the appetitive mechanisms and their treatment implications, and then conclude with our latest thinking on how these two sets of mechanisms might be jointly targeted in treatment. So beginning with the threat system, I'm going to briefly review some of the accruing evidence for dysregulation in the threat system as a contributor to anxiety. And then I'll talk about how that dysregulation interferes with the critical process of extinction learning throughout exposure therapy, and then give you our latest work on how do we optimize extinction learning throughout exposure therapy in order to improve its effectiveness. So briefly, my longitudinal research over a number of years, along with my collaborators, has demonstrated what I would call an elevated threat reactivity, which is a contributor to the onset of anxiety and in many cases the onset of depression as well. And that threat reactivity is shown in the trait of neuroticism, which is the vulnerability to experiencing negative emotions in response to stresses or even without stresses. And that we've shown in our longitudinal work is a predictor of the subsequent onset of anxiety as well as depression. Then we have dysregulation in the HPA axis, particularly in terms of cortisol awakening response and the diurnal rhythm of cortisol as a predictor of not only depression, but also the onset of anxiety disorders in the future. And then we have quite a bit of work on cognitive biases or threat-laden biases in the way people attend to and interpret ambiguous information, again, as a correlate of risk and a predictor of anxiety. So this is all interesting, but more interesting, I think, is how do this elevated threat reactivity impact the fundamental processes of fear learning, which is what we end up seeing clinically. And so let's take, for example, this sort of innately aversive experience at the top here of being rejected. Social rejection is one of those innately aversive, unconditional stimuli that we all react to. Well, what we have found is that individuals who are at risk for anxiety or with anxiety and have this elevated overarching threat reactivity show patterns of overgeneralization. So after an innately aversive experience like being rejected or being hurt, the fear, which normally will spreads much more widely in those who have these anxious vulnerabilities. And secondly, we know that they also show a pattern of weakened extinction, so that after an aversive experience, subsequent experiences of, let's say, social affiliation without being rejected should lead to a new association, a new memory being formed that, oh, rejection is unlikely. But in persons who are at risk for anxiety or with anxiety, the belief of being rejected tends to persist. They show weakened extinction. And we also know that overgeneralization contributes to that weakened extinction. And then, of course, we have this pattern of avoidance behavior, where individuals who are at risk or with anxiety preferentially avoid potential threat, even at the cost of loss of reward. And of course, if one avoids those situations, then it completely blocks the opportunity for extinction to take place at all. And so those memories of having been rejected are sustained over time. And we've looked at this. This is just to show there's many studies where we've tried to look at these features of overgeneralization and weak extinction, and we look at them in terms of subjective report, autonomic measures like skin conductance, blink of the eye blink startle as a measure of defensive responding, and neural or brain activation patterns. So I'm not going to go through all of those by any means. I will show you some of the more recent findings where we take a standard fear conditioning paradigm, Pavlovian fear conditioning, where we take people through what's called acquisition, where they are pairing a CS, which happens to be a color of the lamp in a room, with shock. And we actually have two CSs, two different colored lamps that are paired with shock over 8 times each, and then what is called the CS minus, which is another colored lamp that's never paired with shock. So they go through standard acquisition, then they receive extinction to one of the CS pluses that had previously been paired with shock. So now in extinction, no more shock. And then the CS minus that was never paired with shock is repeatedly presented. And then 24 to 48 hours later, we bring them back, and this is really a critical test of extinction recall. How much do they retrieve what they learned here during extinction? So we present all of the stimuli again without any kind of shock being presented. So we did this in a number of different studies. The one I'm showing you now is 273 18 to 19-year-olds who we followed for 30 months. And we conducted this Pavlovian fear conditioning in the MRI scanner. We're looking at fMRI. This is difficult to read perhaps, but you can see all of the threat neurocircuitry listed along the bottom here: amygdala, hippocampus, anterior, insular, dorsal, anterior cingulate, subgenual ACC, VMPFC, and BNST. Here's acquisition, extinction recall, and you can see that we're getting that CS plus versus CS minus, comparing the stimulus that was paired with shock, the stimulus not paired with shock. We're getting those nice differences at baseline and 30 months later. It extinguishes, so you see a loss of that difference between the CS plus and the CS minus. And an extinction recall, we see different patterns emerging. So people are not always able to retrieve that extinction memory. So we did a multivariate regions of interest analysis. So we took all of those regions that I just showed you at baseline and said, does the neural pattern of responding at baseline predict the development of the symptoms over the next 2.5 years, the next 30 months in this group? And what we found is that during acquisition, so during that time where we're pairing one stimulus with a shock and the other stimulus no shock, the discrimination between those two did predict the level of fear development over the next 2.5 years. And specifically, it was driven, interestingly, by the ventral medial prefrontal cortex, which we think of as an inhibitory regulatory region within the fear conditioning world. And what you can see is those individuals who showed a pattern of their fears getting bigger, their fears spreading over time, over the next 2.5 years, had much less discrimination between the CS plus and the CS minus than those whose fears did not worsen, in fact, may have even contracted over those 2.5 years. And so we look at this as evidence of overgeneralization, particularly because the VMPFC, there's some research to suggest that its suppression, which is what we're seeing here, suppression of the VMPFC is allowing the expression of conditional fear. And so you see the expression, ideally here, of conditional fear in those whose fears did not expand. And we don't see that separation between the CS plus and the CS minus. So this is, in our minds, an example of overgeneralized responding. Now, conversely, if we go to, I've got too many things going here. If we go to the extinction recall phase, so this is when they come back 24 to 48 hours later, back in the scanner, we're testing how do they retrieve the memory of that extinction. What we find here, the multivariate analysis of variance that included all of those regions of interest, found a pattern that those whose general distress, now general distress is the negative affect that's shared between anxiety and depression. It's not fears, it's that anxious, depressiveness, negative feelings that's shared. As that worsened over the 30 months, we see evidence of poorer extinction recall, and specifically driven by the subgenual ACC, another regulatory region. And what you're seeing is less activation of the subgenual ACC in those whose general distress worsened versus those whose general distress did not worsen. And because the subgenual ACC is thought of as an inhibitory region, you want it to be inhibiting responding. This we see as weakened extinction in those whose general distress worsened. Complicated set of results, but very similar to a bunch of other studies using different measures. So overgeneralization, weak extinction seem to characterize or predict the development of anxiety and fears. And so we see these characteristics of overgeneralization, weak extinction, avoidance, leading to the spread and persistence of fears, thereby becoming chronic anxiety disorders. Exposure therapy. The whole goal of exposure therapy is to replace avoidance behavior with approach behavior so that there can be new learning that takes place. And the new learning is extinction learning, to develop a new set of associations that say, oh, that prior threat is no longer happening. But what I've just showed you is that there are deficits in extinction learning in people who have anxiety disorders, and those deficits may contribute to their anxiety. So exposure therapy is dependent on the same processes that are deficit in these individuals. And hence, even though they go through repeated positive experiences, that memory of whatever it is that was involved in rejection in this case sustains over time. They don't update their beliefs. And so that may explain why we see an upper limit on effectiveness, because we're relying on a mechanism that is already deficit in these people. And it may explain why after exposure therapy is completed, you see anywhere from 25 to 50, 60% of people showing what's called a return of fear. If you put them back in the situation that they had previously done exposure therapy to, their fear resurges afterwards. And so that leads us to say, what can we do to optimize extinction learning during exposure therapy? How can we maximize, how can we help these individuals really develop better extinction skills, basically, throughout exposure therapy? So To do that, we developed what's called the inhibitory retrieval model of exposure therapy. I think I'll just skip this because it's a lot of detail, but just to say the inhibitory retrieval model of exposure therapy emphasizes prediction error, that we learn by surprise. Extinction occurs through the process of prediction error. When you expect that innately aversive event to happen and it doesn't actually happen, that mismatch, that error in your prediction, drives new extinction learning. So that's where we put a lot of our emphasis on that prediction error learning. We're also recognizing that new learning is not erasing old fear. It's now sitting side by side in the same. So you've got this individual now who has the old sort of fear memory of being rejected. We're trying to develop a new memory of not being rejected, but these things exist side by side. You don't erase the old one. It's very difficult to erase fear memories. And this new association is context dependent, and it has to be for evolutionary reasons. Extinction should always be tied to the context in which it took place. So that means after exposure is over, there's a vulnerability if the person faces the thing they were afraid of in a brand new context, that you might see a return of fear because the original fear memory will dominate. So very tricky to deal with. So over the years, we have done many studies trying to focus on how, in these individuals who have weak extinction, how do we strengthen the development of those inhibitory associations through prediction error. So all of these different studies that we've done, and it ties into their attention, it ties into safety signals, it ties into how do we label experiences, and how do we help consolidate and retrieve those new associations in new contexts. So how do we overcome this context specificity effect? And the ones that are in blue are just the more recent ones that we've been focusing on. We did a very large-scale study using cholinergic receptor antagonists, particularly scopolamine, in order to try to attenuate the effect of context, override context effects. We've done a lot of work on consolidation through mental rehearsal and retrieval-induced forgetting. So I'm not going to go through all those, just to show we've done a body of research trying to pull all these things apart into specific studies that we can look at these ways of optimizing learning. And most recently, we put it all together into a package, or most of those strategies into a package. So this has just been published in JCCP. And we said, let's take our inhibitory retrieval model, which is supposed to be about enhancing extinction learning in individuals who have these vulnerabilities, and compare it to a straight-out habituation model. And the straight-out habituation model is the way that exposure therapy is typically done. And we did this in individuals with social anxiety disorder or panic disorder. They were randomized to one of these two conditions. Everybody gets only 9 sessions of treatment, and 8 of those sessions have exposure therapy. We do nothing else. It is straight out exposure therapy, and it's all conducted in session with homework practice between. So it's very tightly controlled. Here's the habituation model, and those of you who are clinicians may be familiar with this. You set up a fear hierarchy. You emphasize what we're going to do is start with the mildly to moderately fearful situation, and we're going to repeat it over and over and over again until your fear declines. And then we're going to show you that. See, look, here's your fear declining. And that's very reinforcing to people. Oh, my fear is declining. And then you repeat the exposure until their initial level of fear is quite low, and then you go to the next step on the hierarchy. So that's the traditional habituation model, and I think most people use that. The inhibitory retrieval model does not focus on fear reduction at all. There is no fear hierarchy. It's an associative map where we try to link what are the things that predict the feared outcome. How do we identify what blocks that prediction? What's the most significant thing that you think is most likely to predict that worst outcome for you? And what are the occasion setters versus the conditional stimuli? So it's all based in, Pavlovian extinction framework. And then we do everything to violate. This is prediction error. We set up the exposure to, if you think you're going to faint after standing for 5 minutes in a very hot room, not before 5 minutes, but after 5 minutes, you think the chances of fainting are really strong, we're going to go for 6 minutes or 7 minutes. We're not going to bother with 1 minute or 2 minutes because there's no learning there. There's no violation of your expectancy. So everything is designed to violate the expectancy. And then we do a lot of things, how to train attention, how to consolidate. I'll show you that in a moment, how to vary things up. We do deepened exposure. As a simple example, if you're afraid of spiders, deepened exposure is you have one spider in one hand and another spider in the other hand. Because if you have 2 spiders and you still don't get bitten, that's more prediction error. An occasional reinforced exposure is where we will occasionally bring in the US, we'll bring in that innately aversive experience in order to learn that on subsequent trials it doesn't occur, because every time we bring in the innately aversive experience, the expectancy on the next trial goes way up, and then you've got more chance of prediction error happening. So there's a lot of strategies going on here, but at its core, we're designing exposures to violate expectancy. What did you expect to happen? And this is what we look at afterwards. What happened? What surprised you? What did you learn? There's no focus on fear reduction at all. And in fact, sometimes we want fear to be high and sustainably high because their prediction is, I will pass out if I'm afraid. So we have to elevate fear and keep it elevated to test out the prediction. So it's a very different way of doing it. Both treatments work, but we get a benefit from the inhibitory retrieval condition. So you see here that this is the symptomatic improvement over time throughout all the sessions out to 3-month follow-up. The slope of reduction in the inhibitory retrieval condition is significantly steeper than for the habituation condition. More participants achieved clinically significant change defined by being reliable change that ended up below a cutoff in the inhibitory retrieval condition compared to the habituation condition at post with trends at follow-up. When we asked them to get up in front of an audience and give a speech at pre and post, we got significantly greater improvement in the inhibitory retrieval condition compared to the habituation condition. And this all occurred with much less time spent in exposure. So using the inhibitory retrieval condition, we ended up with less than half the amount of time in actual exposure than in the habituation condition, because the exposures were designed precisely. Now, we also looked at mechanisms. So in the habituation condition, fear reduction is the mechanism, right? If your fear reduces from before to after, you've done well. So we look at that. Fear, what's your fear before you do exposure, and afterwards, what's your fear now? And we look to see, does that fear change predict symptomatic improvement at post and at follow-up in the habituation condition? It does not. The amount by which fear changes in the exposures does not predict symptomatic improvement at post or at follow-up in the habituation condition, nor does it predict it in the inhibitory retrieval condition. Think about that. How much fear declines as you take the person through exposure is not predictive of how well they're doing overall. That's a hard one to get your head around. I think of it as fear in the moment is just a performance. It's not learning. We want better measures of learning. And this replicates prior work we've done, where we've established perhaps the most stringent trial. We had people with public speaking fears and social anxiety disorder. They went through 49 exposure trials. 49 times they spoke in front of an audience over 7 exposure sessions, and they did exactly the same task every time. So we got massive changes, but that did not predict how well they were doing from pre to post to follow-up in terms of their overall social anxiety disorder or fears of public speaking. What about the inhibitory retrieval condition? Here, we're trying to change expectancies because that's our index of prediction error learning. So before we go into an exposure, we say, what's your expected likelihood of your feared outcome occurring? What's the likelihood that you're going to pass out? What's the likelihood that you're going to be rejected? And then afterwards, after they finish the exposure, we say, if you were to go into that same situation again, what's the likelihood that that bad thing would happen? And we're hoping that there's a reduction in the expectancy because they've learned from the exposure, oh, it didn't happen. That expectancy change is a predictor of symptomatic outcome at post and at follow-up. And even when you do a computational model, this comes from Tomislav Zabozniak in my lab, if you use the US expectancy data to create a computational model of learning rate, that also is a predictor of symptomatic improvement at post marginally and at follow-up. And this is over and above fear reduction, by the way, in both cases. And that's replicated in another study with another set of people who have fears of public speaking, where the learning rate predicted symptomatic outcome above and beyond fear reduction itself throughout the exposure trial. So now we're looking at, okay, these two treatments work. Inhibitory retrieval seems to do better. And it seems to operate according to the purported mechanism. But maybe we should see, maybe there are some people who do better with habituation, and we'll test that out. I'm going to switch right halfway. I'm 12:30. Great. I'm going to switch to the appetitive system and then try to bring these two things together. So I want to quickly focus on low positive affect as a risk factor for anxiety and depression, the reward-related mechanisms, and now a new reward-related treatment. So years ago, we established in our longitudinal research that not only high negative affect, but low positive affect, and these are not different ends of the same continuum. They're two separate dimensions. So low positive affect was a predictor of the subsequent development of not just depressive disorders, which we kind of already knew, but also anxiety disorders. We've also shown that positive affect buffers the impact of chronic stress on the development of depression and anxiety. More recently, we've shown that higher anhedonia, which is low positive affect, predicts chronic interpersonal stress, which then spins around to predict more anhedonia. And we've looked at potential cognitive mechanisms, and it all has to do with if you're in a state of high positive affect, you're more likely to interpret ambiguous scenarios in a positive way. Makes sense. Or you're less likely to interpret negative images. You're better able to reappraise negative images. There's other work I'm not going into, but the summary is positive emotions appear to have a protective influence upon depression and anxiety, sometimes in interaction with negative life events. What is the appetitive reward mechanism here? What's going on? Now, when we think of the reward mechanisms, there's a bunch that have been identified. It's the valuation of reward, the anticipation of reward, the consumption or motivation or learning of reward. These are all different. Am I double? Is there two of me somewhere? Okay. Attempts to distract. So if we want to look at the consumption of reward, one way to do that is to present positive stimuli and just see how do people react to these positive stimuli. So we can show images like this and just sort of measure, how do you react when you see this or this or a beautiful landscape of nature or kids having fun? Well, we didn't actually use those beautiful images because we were stuck with the International Affective Picture System, which is much worse than that. It's really not good. They need to update it. But anyway, even with the International Affective Picture System, if you take the positive images within that slide set and then just have people rate how positive do you see this, or how positive does it make you feel? And this is 172 anxious, depressed primary care patients. On each y-axis, the higher the score, the higher the positive affect. The lower the score, the more anhedonic. Higher is higher positive affect, I should say. And as you can see, and this is the rating of positivity. So it's just a nice sort of direct correlation. So if you have higher positive affect, you likely are going to rate these kind of things more positively. Not at all surprising. So then we did the monetary incentive delay task. This comes from Brian Knutson's work. And in this task, you're given a series of trials and you're told, hey, in the anticipation phase, you're about to win some money or you're about to lose some money. And then you're given a quick interval of time where you have to respond to a target quickly in order to attain the win or prevent the loss. And then there's a consummation phase where you're told how much you've won or how much you've lost. And this task has been used many, many times. So this is our 273 18 to 19-year-olds, the same group whom I showed you about the fear conditioning. We did this task as well, the MID task. We looked at the reward circuitry, the OFC, a regulatory region, the ventral striatum, and the putamen and pallidum. Rick Zinberg, who's my colleague, loves to do structural equation modeling, so this is what he did. So in the anticipation phase, we have the observable indicators are the putamen, pallidum, and the ventral striatum. The consummation phase, the same three, but the orbital frontal cortex was kept off as an observed variable. And then we looked to see whether these two constructs or the observed OFC related to our symptom patterns. And the only symptom that it related to, and this was just during the consummation phase, not the anticipation phase, the only pattern we got was that a negative relationship between anhedonia and activation of the orbital frontal cortex. So with more anhedonia, less activation of the orbital frontal cortex, under activation of the orbital frontal cortex. And that was specific to anhedonia. It wasn't relevant for general distress, that negative affect, nor fears. Interestingly, we got a really similar set of findings from the 172 anxious and depressed primary care patients in whom we also did the MID task. Not a great image, but basically this is showing, I'm sorry about this, but here, the higher the score, the greater the anhedonia, and because we reverse scored. And what this is showing is with higher anhedonia, you're seeing less activation again of the orbital frontal cortex. So together, these two studies, and others have done this too, Diego Pizzagali's group and others have certainly shown this, that you're seeing what looks to be underactivation of reward regions that should be more engaged in these processes, particularly for us in the consummation phase. So there's, as I said, a lot of work being developed, showing that low positive affect or anhedonia seems to be associated with reward deficits. Deficits in the capacity to show interest or motivation, Michael Treadway's work, or learning of reward, Diego Pizzagali's work, or consumption of reward, what we've been focusing on. So the question is, how do you raise positive emotions in somebody who has these kind of reward deficits? And this is an important question because existing treatments don't do a great job of this, whether it's psychological or pharmacological. Maybe ketamine will shine out. Maybe some of the L-DOPA work will shine out, but right now, existing SSRI, SNRIs, and psychological CBTs don't raise positive emotions very well at all. So we developed positive affect treatment. You'll notice a theme in my work. I like boxes and lines with here's the therapeutic ingredient and here's the mechanism. But this treatment is all about reward mechanisms. We do not touch negative emotions. So we're going to be dealing with patients walking in the door, very depressed, very anxious, and we're only focusing how do we increase their capacity for reward. That's all we do through a number of different strategies that are shown here. And I should say, you know, I line it up. This strategy associates with this reward mechanism. This strategy associates with this reward mechanism. There's a lot of overlap. And we know there's a lot of overlap. These things feed off each other. The anticipation influences the consumption, influences the valuation, and so forth. And in fact, in an EMA study, we've shown exactly that cycle where the interest and anticipation predicts the subsequent enjoyment, which predicts the subsequent interest and motivation. This positive affect treatment starts with behavioral activation. That's not new. We've already done that for a long time. You just get people to go out and do things that are rewarding. The real meat of the treatment is when they come back in, we spend 20 to 30 minutes having them relive in first person, present tense, from their own eyes, the experience. What was the situation? What did it feel like in their bodies? What was the meaning of it for them? And this kind of experiential processing of a positive event, we had already shown in experimental work to be much more effective than a third-person narrative description. So if you just get people to describe what happened, you don't get the benefits in terms of their positive affect. You see more positive affect with the experiential, less negative affect, and you even get less what are called dampening appraisals. Dampening appraisals are things like, this is not going to last. I don't deserve this. Even that is affected by this experiential processing. So they do experiential processing followed by some cognitive skills. This is not cognitive restructuring. It's literally training attention to positive events. So you felt like the dinner party didn't go well. What did go well there? But it wasn't so good. What did go well? So we just keep reallocating attention over to the positive. That we teach them to take ownership of positive outcomes, to imagine positive future. And then the last 4 sessions draw heavily from mindfulness research on appreciative joy and gratitude and so forth. All right, first study, 96 patients. We randomized them to positive affect treatment or to a comparison treatment, which we called negative affect treatment. So it became PAT versus NAT. And negative affect treatment is more like traditional CBT. It's exposure therapy, it's overcoming avoidance behavior, it's cognitive restructuring where we teach people to reappraise, it's arousal regulation where we do slow breathing exercises. So we randomized them, we measured their affect and their symptoms, and positive affect treatment did significantly better in increasing positive affect up to normative levels in the population, not previously achieved. Surprisingly, it was also better at reducing anxiety and reducing depression and suicidal ideation that I don't have here. Study 2. Again, we selected individuals who were depressed or anxious. Now they had to have severely low positive affect. We randomized them, we did the same thing, but we also added measures of reward processing. Again, positive affect treatment led to significantly greater improvements in positive affect, significantly greater reductions in depression and anxiety, and significantly greater improvements in our target measures of reward. So their capacity to anticipate reward was improved more in positive affect treatment than negative affect treatment. And we measured that in multiple ways, and the target changes correlated with outcomes. They also improved more in terms of consumption of reward. So positive affect treatment led to greater change in the consumption of reward, and that particularly on the self-report and cognitive measures. This one, by the way, I should have said was heart rate to the anticipation of money. This is how much do you attend to positive versus negative stimuli. And those changes correlated with symptomatic outcomes. And then we didn't get anything with the learning of reward. I have to work on that with Diego. Study 3, under review right now. 100 patients, same thing, clinically depressed or anxious, very severely low positive affect, randomized. This time, we added a threat sensitivity target. So our hope was positive affect treatment would lead to more change on these targets, the reward targets, and negative affect treatment would lead to more change on threat targets. So overall, clinically, positive affect treatment still does better than negative affect treatment. So the multivariate outcome, when you combine all these things together, this is positive affect. This was a new measure, an anhedonia interview measure, which didn't come through. And then the total of the depression and anxiety scales combined. So positive affect treatment still performed better. However, as happens in research, our threat and reward targets didn't come out as we wanted. Both treatments, both positive affect treatment and negative affect treatment, increase reward responding, both the anticipation and consumption of reward. Threat responding decreased in both treatments, and for that we used like a mental arithmetic stressor test where they had to perform like a TRIA stress test kind of thing. That decreased in both treatments, but it was more reduction in the negative affect treatment. So there's specificity there. And then we did full-on mediational modeling because we were able to do that with temporal precedence. And that was strange because reward, anticipation, and consumption did mediate clinical outcomes, but to the same degree. There was no difference in mediational strength between positive and negative affect treatment. And decreased threat processing did mediate clinical outcomes, but again, no difference in the strength of mediation between positive and negative affect treatment. So we have to go back to the drawing board a little bit there. And now we're looking at, okay, who responds better to positive affect treatment versus negative affect treatment? I have a suspicion that those who have real panicky kinds of anxiety may still respond better to NAT than PAT, but that's just a suspicion. All right, I'm going to finish up in the last 5 to 10 minutes of trying to bring these two different domains together. How do we think of reward processing in exposure therapy? So I'm going to focus a little bit about how the low positive affect impedes extinction and how can we improve exposure therapy based on that. What makes us think that low positive affect impedes extinction? Well, we had done a bunch of studies, as always, over the years, and we had found that if you rated the thing that you were extinguishing more positively, like if you treat somebody with a blood injury injection phobia, they're not only less fearful of the needles, but now they say, I like needles, which is unusual, by the way. But if they say they like needles, they'll show better long-term outcomes than if they say, I still hate them. So we did that experimentally. We also found if you induce positive affect by just exposing people to lots of positive images before they go through extinction, it gives you better long-term extinction. And individuals with higher positive affect as a trait show better long-term extinction. So we had that inkling. And then, now, from that neural data, before I showed you the acquisition, and I showed you the extinction recall from that Pavlovian work, this is now the extinction phase. So in the middle of extinction, you've got a very clear pattern that as anhedonia increases, this is along the x-axis, you see, and this is at the end of extinction when there should be no more discrimination between the CS plus and the CS minus. The individual should have learned, oh, that thing that used to be shocked is no longer being shocked. So it shouldn't differ anymore from the stimulus that was never paired with shock. They should have extinguished. But look at this. Anhedonia increases. You're seeing increased reactivity to the stimulus that previously was shocked, even though it's no longer being shocked, compared to the stimulus that was never shocked. That discrimination is a sign they have not extinguished. And it happens in many of the regions from the threat circuitry. the BNST, the amygdala, the insula, the dorsal anterior cingulate cortex. So something about anhedonia means they're not extinguishing very well at the neural level. And I won't spend time on this. We also, not me, Ben Rosenberg, my colleague, did this in terms of a multivoxel pattern decoder analysis, where during extinction, they were able to decode anhedonia and only anhedonia. So this is saying anhedonia seems to be specifically, not general distress, not fears, but anhedonia itself seems to impact extinction, the process of learning throughout extinction, in a negative way. What could be the mechanism? Well, here we turn to my colleagues Bram Vervliet and Raphael Kalish, who have said, you know what? Prediction error learning, that thing we talked about before, where you suddenly realize, hey, that negative event didn't occur, is actually a better than expected outcome, which has its own positive hedonic value. Sometimes that's referred to as relief. Oh, it didn't happen. Oh, that feels good. And in fact, other research has shown if you silence dopaminergic neurons in the site of prediction error learning, so if you kind of interrupt the reward pathways during extinction learning at that site of prediction error, you can actually block extinction from taking place at all. So anhedonia is associated with dysregulation dopaminergically, is associated with undervaluing or less hedonic reactivity. So maybe what's happening is that anhedonia is interfering with prediction error learning. So, in other words, at the clinical level, anhedonia or low positive affect may be impairing how they are learning from that prediction error experience throughout exposure therapy. The negative event doesn't happen, but they don't learn from it. And remember, this is how we measure it. We measure it in terms of expectancy change. From before you go into the situation, what's your expectancy of that negative outcome? And if you were to redo the whole thing again now, what is your expectancy? We want that to drop significantly. And we indeed find in a sort of secondary analysis that the level of positive affect that the person is experiencing at the moment as they go through an exposure trial relates to expectancy change. Complicated, as everything tends to be, unfortunately, but here, these are the trials when expectancy is very high. They're going into the situation saying, I'm 90% sure I'm going to faint. If at the moment their affect is high, which is the blue line, their post-exposure expectancy, when we say, if you redid this again, what would be your expectancy, is much lower than if their positive affect was low. Do you get that? So at the moment of thinking the bad thing is going to happen, it doesn't happen. If you're feeling pretty positive, you're more likely to say it's probably not going to happen again in the future either. And that's expectancy change. That's what we want. And we also, so the higher the positive affect, the better the prediction error learning. And we also confirmed that with some natural language processing where we looked at sentiment, which I'll skip over. Why is this important? Because as I showed you before, prediction error learning, expectancy change, predicts long-term outcome. So that means where we're at right now is focusing on how do we enhance reward processing either before or as people are going through exposure therapy. So we have two trials going on. One is we do the whole positive affect treatment for 4 weeks condensed before they start exposure therapy to see if we can raise positive affect so that they're going to benefit more and learn more from the prediction error during exposure therapy. We've also tried neuromodulation using low intensity focused ultrasound to try to target the nucleus accumbens, results pending. We did another study over here where after exposure was over, we trained people to really savor the fact that that negative event didn't happen. Like that felt, what did that feel like when you suddenly realized you weren't rejected? Unfortunately, that had no impact whatsoever. So I wouldn't bother with that. But our hope is here, I think, primarily. We've already demonstrated this experimentally, and others are doing counter conditioning. I know I'm a little bit out of time, but I want to show you one last thing because it's very exciting. It's a novel approach to harnessing reward principles through unconscious exposure therapy. This is a totally different area. And so this comes from my collaboration with Hak-Wan Lau, who was at UCLA for a while, and now Cody Cushing, who's my postdoc who runs these studies. All right. So what we're going to do is we're going to treat a phobia without the person ever consciously knowing what they're being exposed to. So we take individuals who have at least 2 animal phobias, have to be clinically significant animal phobias. We have them exposed to a whole series of images along with a group of healthy control participants. So they look at 3,600 images of animals while they're in the scanner in order to assess the neurovisual representation area of the brain response, the ventral temporal area. So we're looking at the ventral temporal signature or response to these kinds of images. The phobic people never look at their own phobic stimulus. Then, through hyperalignment and machine learning modeling, we estimate how would the phobic person's brain respond if they were to be a non-phobic person, a control person. You with me? So how would they react how can their brain match a control subject in this ventral temporal area? And then we train them to do that. We train them to match the control subject through a reinforcement paradigm. So we start off with a test. We just, we start off with that decoder construction where we show them all the images and we try to construct what is the ventral temporal area doing in phobics and non-phobics. We then do a test. So we look at how much fear, what's their affective stroop, what's their amygdala to their phobic stimuli. Then we take them through neuro-reinforcement. So now the phobic people are being exposed to a series of trials where all they see is a disc. And they're told to make the disc as big as they can, doing whatever they want to do. And every time the disc expands, it actually means that in real-time analysis and feedback, they're getting closer and closer to what the non-phobic brain would look like, to the phobic stimulus that the participant has. You with me? And then they get reinforced with money every time the disc gets bigger. So they're trying to make their brain match the non-phobic person's brain to their phobic stimulus without seeing the phobic stimulus. And then we test again. And then what we found in our first trial, which was 23 participants, remember, every phobic person had to have 2 animal phobias. One of them was the target of neuroreinforcement, the other was not. And it was all blinded. They didn't know which one was being targeted and which one was not, nor did the assessors know. So it was a double blind within subject control. And this is pre-to-post change in amygdala. So if the phobic stimulus was the target of neuroreinforcement, you see a greater reduction in amygdala reactivity. Remember, this is the amygdala, not the ventral temporal area, which is where the brain was focused on matching. But now the emotional response, the amygdala reactivity, has lessened in comparison to the phobic stimulus that was not the target of neuroreinforcement. And similarly, their stroop reaction time was slower. that there was a greater reduction, in strip reaction time. And so we now have a big trial going on with 80 participants. We're about a third of the way through. You might say, why are you doing this? It's really complicated. And it takes a lot of work because we have to bring people in over and over again and doing repeated fMRIs. Some of them are getting 5 sessions of that neuro reinforcement. The reason we're doing it is because up to 33% of individuals with phobias refuse exposure therapy. It's too anxiety provoking for them, or at least they think so. And so this is unconscious exposure therapy. So we'll see where it goes. So that's my update on defensive and appetitive mechanisms. And to lift you all up as you leave this room, I'm going to show you some positive images. And this is my home, Tasmania. This is some of the beautiful landscape. We have rainforests in Tasmania, which you wouldn't necessarily think because it's not a very warm place. This is my favorite beach, Horseshoe Bay. And here are the Tasmanian kangaroos, the Tasmanian wombats, and yes, the Tasmanian devils. Thank you. So I know I'm at 1 o'clock, but I'm happy to stay if other people want to come up for questions. Yeah.